Good afternoon. Welcome back to Grand Rounds today after our 2-week hiatus. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations that you picked up on the way in, and please give the CME committee any ideas you might have in regards to future topics or future speakers. Today it's my pleasure to introduce Dr. Mike Kitchell. Dr. Kitchell is board certified in neurology and neurorehabilitation. He's the medical director for the inpatient rehab unit here at MGMC. He has kindly accepted our invitation today to give us an update on Parkinson's disease. The good news is that he's able to keep his commitment today. The bad news is that the potential conflict he would have had with traveling to the NCAA tournament this week never materialized. So please join me in welcoming Dr. Mike Kitchell.
Yeah, the thing that I get energized about is a Cyclone Basketball, but as you know, they are pretty inconsistent, so I hope my lecture today is a little more consistent at keeping your attention. So the basic problem in Parkinson's disease is that there's a loss of the dopaminergic activity in the brain, and that is basically located primarily in the basal ganglia and in the brainstem called the substantia nigra. Just like in Alzheimer's disease, where there are neurofibrillary tangles and senile plaques and amyloid deposits, in Parkinson's disease there are what are called Lewy Bodies and alpha-synuclein deposits. So these are the characteristics of a person with Parkinson's disease. We don't know the cause, but there are two main areas of focus. One is potentially some toxins, because we do know that there are toxins that are in the environment that can cause Parkinson's disease in animals and in humans. And then there's also the possibility that there was some infection sometime in a person's life that caused some weakening of some of these dopaminergic type of cells. So I'll talk a little bit more about that. There is a hereditary predisposition to Parkinson's disease, but it's not strongly hereditary. As you probably know, the average age is somewhere between 65 and 70 years of age for the onset of Parkinson's disease, but obviously the incidence goes up as people get older. There are a few people before age 50. For example, Michael J. Fox was diagnosed as having Parkinson's disease when he was in his early 40s. So it does happen in younger people. And all of us have about a 2% lifetime risk of developing Parkinson's disease. And as you know, the tremor is a very characteristic aspect of Parkinson's, but we do want to differentiate that from another disease called essential tremor. And that sometimes is the reason neurologists get to see people, is it might be an essential tremor or it could be a Parkinson's tremor. But the other features that definitely cause us to make the diagnosis would be the bradykinesia, that is the slowness of movements. For example, when we have people tap their fingers or flip their hand, those dexterity type movements are slower and more difficult. And then, as you probably know, people with Parkinson's disease have increased muscle tone or rigidity. They do have trouble getting up out of a chair because they are not only slow, but they're stiff. They do have gait problems in most people with Parkinson's disease too, and those gait difficulties are the hardest part of Parkinson's to treat. Many people with Parkinson's disease actually start having symptoms on one side. That's actually not a bad sign in people who have unilateral Parkinson's disease at the onset. Those people generally have a better prognosis than if they have it on both sides. So, as I was saying, there are symptoms and types. Those people who present with a tremor as their main symptom, they actually have a pretty good prognosis. But only about 75% of people with Parkinson's disease have a tremor. In other words, you don't have to have a tremor to have Parkinson's disease. And so the people who are slow or stiff, that's called the akinetic rigid type of presentation, those people could have Parkinson's disease or they could have a Parkinsonian syndrome. And so I'll explain that in a little bit. Not everyone with Parkinson's symptoms has Parkinson's disease. And so I'll talk, like I say, a little bit more about that Parkinsonian syndrome. Then people who have a gait disorder, usually a slow shuffling, unsteady gait, those people have what we call postural instability. They don't keep their balance very well. That is more difficult to treat. So as I said, we need to differentiate between a Parkinsonian syndrome and Parkinson's disease because the prognosis is definitely different for those people. So the typical problems in Parkinson's patients are a short shuffling gait. They don't swing their arms when they walk. They have trouble getting out of a chair or out of bed. They are slower when they dress. They need help with buttons or shoelaces or buckling a belt. In people with Parkinson's disease, they often have smaller handwriting. It may not necessarily be a tremor, but it's smaller and it's harder to read, obviously. In many people with Parkinson's disease, their voice is hoarse or soft. We call it hypophonia. They don't project their voice very well. And then, as you probably know, drooling is a common symptom in Parkinson's disease, and it's associated with fewer swallows. They don't spontaneously blink as often. They don't spontaneously swallow as often. So the drooling is simply reflecting that fact that they don't swallow as often. A lot of people with Parkinson's disease have muscle aches, particularly if they have a dystonia. Some people with Parkinson's will have a dystonia of their neck or their back. Some people are bent over. Some people are bent to the side. Some people have a dystonia in their foot, so their toes are going down or their toes are twisting. Those muscle aches can be a real problem, too, with some of the people with Parkinson's. And most people with Parkinson's disease are sleepy during the day. They have excessive daytime sleepiness. Some people with Parkinson's have trouble sleeping at night, but other people just tend to sleep many more hours a day. About a third of the people with Parkinson's disease can have some depression or mood changes, and a lot of people, perhaps a third or a half, eventually will have some difficulty with their thinking. They'll have trouble concentrating. Their thinking is a little slower. Constipation is a real problem for a lot of patients. Most people with just pure Parkinson's disease don't have incontinence, but there is a Parkinsonian syndrome that I'll talk about that those patients do have incontinence, as well as some autonomic nervous system problems. Many people with Parkinson's disease complain of dizziness, and sometimes that's related to their gait difficulties. Sometimes that's a little orthostatic blood pressure drop, too. I presume most of you know that when we dream, we have a state called the rapid eye movement state. And that dream stage of sleep is when we have rapid eye movements, just like you see in a cat or a dog when they're asleep. You'll see their eyes moving underneath their eyelids. Humans have the same tendency when they're in the dream, deeper stages of sleep. And so what happens when we're in that dream stage of sleep is our brain stem basically turns off our muscle tone, so we don't act out our dreams. But in people with Parkinson's disease or Lewy body disease, those people have what's called a REM behavioral disturbance, where they will be thrashing around. They may even fight their spouse. They might yell or scream. So it might be something you have experienced, that your spouse is yelling because they're having a nightmare, but these are worse than that. This is actually thrashing around, and some people can injure their spouses because of this. So as I said, the Parkinson's tremor has to be differentiated from what we call an essential tremor. An essential tremor is what we call a postural tremor. It would be a tremor at posture. A person who has Parkinson's disease would have more of a reciprocal tremor, or what we call a pill rolling tremor. But I can tell you, after many years of trying to decide, is this a Parkinson's tremor or an essential tremor, sometimes it really is hard to tell. What does make the diagnosis of Parkinson's disease, though, is bradykinesia, slow movements. If you don't have slow movements, you most likely don't have Parkinson's disease. So that can be done by checking the alternating motion rates, seeing whether when they walk, whether they have associated movement or not, and just see. I've seen people at cocktail parties or receptions, and I noticed that they're not blinking, they don't have much facial expressivity, and I think, oh no, they've got early Parkinson's disease. So this is what we as neurologists are looking for, is some of those associated movements that should be present in people, but unfortunately in Parkinson's, those spontaneous movements, those automatic movements are diminished. So they have rigidity or muscle tone increases in the arms, legs, and sometimes in the trunk. As I said, some people with Parkinson's disease have a really stooped over posture. Some people are tilting to the side. Some people have a dystonia in their arm or leg. As I said, the masked face is a very characteristic feature that usually goes along with people who have some drooling or some difficulty with their voice and projecting their voice. Those dystonia problems are really difficult to treat. As I said, some people will complain that their toes are bending down all the time, and it's hard for them to walk because of that dystonia. So they can have some focal dystonias or some generalized dystonias. And sometimes the medication makes people have dyskinesias, which are the twisting or excessive movements. I'm sure all of you have seen Michael J. Fox. He's twisting or turning or grimacing. And those dyskinesias are actually due to a side effect of the levodopa. So that's caused by the medicine. It's not necessarily going to happen in a person with Parkinson's disease unless they're on that levodopa. The majority of people with Parkinson's disease have diminished sense of smell. There are people with Alzheimer's disease who also have diminished sense of smell. That means they can also have a diminished sense of taste, because as you probably know, taste is actually mostly smell. So when a neurologist sees someone with Parkinson's disease, it's really the history that's the most important, but then the neurologic exam, like I say, essentially has to show some bradykinesia. The tremor is not enough to really be sure of the diagnosis, but it is a pill-rolling tremor as opposed to that essential tremor, which is more of a postural or a static tremor. The intention tremor is more often seen in someone who has a cerebellar problem, like a stroke or multiple sclerosis. The lab tests are usually normal. Some younger people with Wilson's disease, which is a copper metabolism problem, they can be Parkinsonian because of Wilson's disease. But we don't really rely on any lab tests to make the diagnosis. A CAT scan or a magnetic resonance scan is usually normal. There is a scan called a dopamine transporter scan that we can get in Des Moines. It's very expensive, so you have to get a pre-authorization to do it. I don't usually do it for older patients, but for younger patients, I will order that. Like I say, the differential diagnosis is really essential tremor. Essential tremor is twice as common as Parkinson's disease, and it is much more slowly progressive. I always tell people about Katharine Hepburn, the movie actress. She actually had the essential tremor of her voice, of her head, and her hands. And by the time she died at age 93, she was not demented and she was not bradykinetic. She just was very tremulous. So that's the differential diagnosis in most cases. And as you know, some patients that are on some antipsychotic medication, dopamine blocking medication, those people can look as though they have Parkinson's disease. I see a lot of people referred by psychiatrists because they want to know if they have Parkinson's disease or if it's a side effect of the medicine. It could even be both. Some people in their middle ages who get dopamine blocking drugs can have early signs of Parkinson's disease. But the antipsychotic drugs, they can cause all the features of Parkinson's, the tremor, the stiffness, the slowness. So those drugs that are antipsychotic and treat patients with psychosis can also cause Parkinson's signs and symptoms. The disease that is one of the Parkinsonian syndromes is called progressive supranuclear palsy. And sometimes when people are presenting with the Parkinsonian syndrome, they don't always have all the features of PSP. For example, PSP has characteristic loss of eye movements. So their eye movements are slow and incomplete. They can't really look up or look down very well. They might even move their head, but their eyes will stay in the same place. So when they're walking down the stairs, they tend to fall down the stairs because they have a Parkinsonian syndrome that makes their balance impaired, and then they can't really see the stairs because when they try to look down, their eyes reflexively go back up. So PSP has characteristic eye movement abnormalities, but sometimes those eye movements are not abnormal for 3 to 5 years. So there are patients who have a Parkinsonian syndrome, and we can't tell them whether it's PSP, whether it's multiple system atrophy, or whether it's corticobasal degeneration until some time has passed. The most treatable diagnosis on this list, though, is normal pressure hydrocephalus. And patients with normal pressure hydrocephalus generally have 3 things. They have a dementia, they have a gait disorder, sometimes their feet just don't pick up and walk, and then they also have incontinence. So those 3 things can help us make the diagnosis. And basically a CAT scan or an MRI scan will tell you whether the ventricles are enlarged and if that's a suspicious patient that we need to do further workup to look for normal pressure hydrocephalus. One disease that I want everybody to really take notice of is dementia with Lewy bodies. I think most of you know the billionaire Ted Turner. I was watching a TV program sometime last fall where he told the interviewer that he had dementia with Lewy bodies. And this is the 2nd most common cause of dementia in this country, dementia with Lewy bodies. And so many of you may not have heard too much about it. But the dementia that does come with Parkinson's disease is basically due to Lewy bodies that are diffusely in the cortex in the rest of the brain. So dementia with Lewy bodies is very similar to Parkinson's disease, but I can talk a little bit more about it later if we have time. Again, dementia with Lewy body patients, they have REM behavioral disturbance, just like Parkinson's patients might have. They have excessive daytime sleepiness. They have fluctuation in their alertness and their memory. And so it's a progressive degenerative disease like Parkinson's, like another dementia, but it does progress more rapidly than Alzheimer's disease does. Alzheimer's disease patients, by and large, should not have any Parkinsonian symptoms or signs. until possibly late in the disease. So if you have someone who has some mild bradykinesia and a mild dementia, look for dementia with Lewy bodies. Dementia with Lewy bodies patients generally are likely to have hallucinations and delusions. They are much more likely to get delirious when they're sick or when they fall and break a hip. So I'm going to talk next about multiple system atrophy. This is, again, another common cause for this Parkinsonian syndrome. And those of you who work at Mary Greeley on our rehab program, we have a lot of people with multiple system atrophy because they are Parkinsonian, they are generally a little demented, and they tend to fall a lot. So when they break a hip, guess where they go? They go to the rehab program at Mary Greeley. And so people with multiple system atrophy do have Parkinsonism, and they do respond at least to some extent to levodopa. They just don't respond as well as people with true Parkinson's disease. But as I was saying, multiple system atrophy is also associated with autonomic nervous system dysfunction. So these people can be incontinent, they can have really severe constipation, and they can have orthostatic hypotension. And some of these patients with orthostatic hypotension, we can try 3 medicines for them. And about all we can do is make them really hypertensive laying down, just so that when they stand up, they don't fade away because their blood pressure drops below 80/40. So it's a real difficult disease to treat. Corticobasal degeneration is also another type of Parkinsonian syndrome. It's much more rare, but people with corticobasal degeneration can have some sensory signs and symptoms. They can have a unilateral neglect. They can have what we call mirror movements. When they try to do something on one side, the other side will do the same thing. So it's, again, a rare Parkinsonian syndrome, gradually progressive. They do have a lot of unilateral signs and symptoms, and they have a lot of dystonia with their disease. In the past 30 to 40 years, I can tell you that strokes are becoming less and less a cause of Parkinsonian signs and symptoms. I think we've done a much better job of treating people with hypertension and vascular disease, so that I think we're not having as many people with what we call the lacunar state, and that is multiple small strokes that involve the basal ganglia as well as some of the white matter. And people who have multiple strokes can have a dementia, they can have incontinence, they can have a Parkinsonian syndrome. But as I said, it's not as common anymore to have multiple strokes as a cause for their Parkinsonian syndrome. Perhaps some brittle diabetics with hypertension and maybe some peripheral vascular disease. The real vasculopaths might be the multiple stroke patients who have some Parkinsonian signs. So again, there are Parkinsonian syndromes and Parkinson's disease. The people who have the best prognosis are the people with Parkinson's disease. The Parkinson's syndrome patients generally don't do as well. So as I said earlier, Parkinson's disease patients have this alpha-synuclein deposition and Lewy bodies, generally in the substantia nigra and in the basal ganglia. But as the years go by, those Lewy bodies can be found in the cortex, and that's where the dementia becomes a greater concern as people get older. The thing we're trying to treat with most people with Parkinson's disease is this loss of dopamine that these areas of the brain produce. And so that's why I'll talk a little bit more about levodopa, which is turned into dopamine in the brain. Those loss of brain cells, though, they can occur many, many years before the onset of Parkinson's disease signs and symptoms. It's estimated that the disease actually starts 10 to 15 years before the symptoms start. If you recall the movie Awakenings with Robin Williams, That dealt with people who had encephalitis lethargica in 1918. And some of these people were teenagers or in their 20s when they got encephalitis. And some of them, a small percentage, but a small percentage of them who had encephalitis in 1918 developed Parkinson's symptoms and signs because of that encephalitis. So that was not a toxin, that was a virus that damaged the brain. These people were in nursing homes and in wheelchairs, and when they were treated in the 1950s, that was the setting of the movie Awakenings, they were given levodopa. And these people who were totally disabled in a wheelchair and not able to walk suddenly awakened, and they were dancing. They went back to living a normal life until some of them got some dyskinesias, and then some of them got the psychoses that some people with Parkinson's disease get. So again, we know that the disease is caused by loss of those dopaminergic brain cells, and we just don't know if it's toxins or a virus that could be causing that. But those progressive loss of those dopaminergic, those dopamine-producing areas of the brain, those are the cause of the progression of the disease. At Iowa State, and I think he's actually given a lecture here, Dr. Kamthasamy, he is in the veterinary medicine college. He's actually working on drugs to block this loss of dopamine cells due to toxins. These toxins I'll talk about a little bit here next. Back in the late 1960s, there was a neurologist in Menlo Park, California, near the Stanford campus in Palo Alto. He found a lot of younger people were showing up at his office with Parkinson's disease. And he said, what is going on? And so there was a group of people who were producing a synthetic opioid drug that if you synthesize something, it might not be illegal because they didn't ban that drug. So they were making these drugs in their garage or their lab and using this synthetic opioid. And unfortunately, sometimes with just one use or a few uses, these people got Parkinson's. And the problem is they didn't get better. I just told you that Parkinsonism can occur because of these antipsychotic drugs, but these drugs, these MPTP drugs, they actually cause permanent Parkinson's signs and symptoms. And so we do know now that this drug called MPTP is a useful drug in research for treating animals and then using that as a model for Parkinson's disease. How many of you use rotenone as an organic pesticide? The city of Ames uses rotenone to kill fish in the ponds around Ames. And they say that it's safe because when it's exposed to sunlight, it breaks down. Rotenone is derived from the roots of some plants, so it's organic and not synthetic, it's organic. But the problem is rotenone can also cause Parkinson's disease. So it again damages, that's why it kills fish, it's toxic. But if you use rotenone around your house, I'd recommend you stop that pretty quickly. Now, for many years, it was known that manganese poisoning in miners and welders was a cause for Parkinsonism. And I just saw a report about a week or two ago that they are recommending that people don't use manganese in their minerals and vitamins because too much manganese, not magnesium, manganese, can also be associated with Parkinson's disease. So again, welders, we do know, are susceptible to that because manganese is a contaminant in the welding field. So as I said earlier, some people who had encephalitis developed Parkinson's disease later that it was a permanent problem. We do know that there's a genetic predisposition It's not high, but it's definitely a problem. Now, I tell my patients all the time, I preach a lot about exercise, and if there's been one treatment that has been shown to be effective for reducing the rate of progression of Parkinson's disease, it's exercise. So whether it's kickboxing or bicycling or some other trendy type of exercise, it doesn't really matter. It's just you need to get people moving. You need to get people exercising. It's well known that some people with Parkinson's disease who have difficulty with their gait and keeping their balance, they actually keep their balance better when they're on a bicycle than when they're walking. So I do encourage people who have Parkinson's disease to exercise. Certainly in the wintertime, we don't want people to slip and fall and break a hip. And so, again, if you want to advise the patients, get them on a exercise bike or some sort of exercise equipment. So, again, exercise is a good treatment. Now, of all the medications on this page, I tend to give the top drugs fewer and fewer times because it's been shown that people who have Parkinson's disease, the levodopa does run the risk of causing the dyskinesias, but unfortunately, whether you use the levodopa early or you use the levodopa later, there's still going to be a time that they're susceptible to the dyskinesias, and so it's not really a big reason not to use levodopa. But if you just want to treat the tremor and Parkinson's disease, Artane or Cogentin are perfectly good. Psychiatrists tend to use Cogentin for the Parkinsonian signs and symptoms. The problem is it doesn't really help the stiffness and the slowness. It just helps the tremor in Parkinson's patients. Amantadine is helpful for fatigue. It's also helpful for people with early or mild stages of Parkinson's disease. And amantadine is helpful for people who have dyskinesias. Dyskinesias actually can be reduced by using amantadine. For younger patients, we sometimes go with these dopamine agonist drugs like pramipexole or ropinirole. Those are also drugs that you might use for restless leg syndrome. So there's no definite connection between restless leg syndrome and Parkinson's patients, but many people with Parkinson's disease do have restless leg syndrome. So that's why these drugs are helpful. For older patients, I generally do not recommend these drugs, especially the Artane or the Cogentin. Those are what we call anticholinergic drugs. So just like the tricyclic medications, nortriptyline and amitriptyline, they are also anticholinergic drugs. They can cause confusion and memory difficulties. So if you have a Parkinson's patient, stay away from those anticholinergic drugs because they can cause absent-mindedness and forgetfulness. And if you have a patient who's having some hallucinations or delusions, you've got to stop those medications because they definitely make people more confused and more likely to hallucinate. These dopamine drugs, pramipexole and ropinirole, also are notorious for causing hallucinations and delusions. So I always have to tell the primary care physicians, if they're having hallucinations and delusions, get rid of everything except the levodopa. And we can't give too much levodopa either, because even levodopa at higher dosages can promote hallucinations and delusions. So as I was saying, the main treatment that we have for Parkinson's disease is levodopa. It's changed into dopamine in the brain. You can't give dopamine by mouth because it's broken down in the stomach. In fact, even the levodopa is metabolized in the gut, and that's why carbidopa is usually given with levodopa. Carbidopa blocks the breakdown of levodopa so more gets to the brain. And as I was saying earlier, there's no medication that is going to slow the progress of the disease down. They've tested and retested, and unfortunately, levodopa or these dopamine agonists, they don't slow down the progression of the disease. They are simply symptomatic treatments. Now, as I was saying, those dyskinesias that you've seen with Michael J. Fox, those can be a real problem. They're usually present in younger people with Parkinson's disease that have been on the levodopa drug for 3 to 5 or 6 years. And those dyskinesias can be really dramatic, and they can be seen in people who have what we call on-off phenomenon. People with Parkinson's disease whose levodopa wears off quickly, and of course it does wear off more quickly as the years go by, they can have these off periods when the dopamine amount is lower in their brain. So those are called on-off effects. So if the patient is about 45 minutes or an hour after they got their levodopa, they're having a peak dose of their dopamine, but that wears off after 3 to 4 hours, then they can suddenly go from being mobile to being off, and we call those sudden off periods a freezing episode. I've had patients who were shaving and they suddenly had an off period and they just went like a statue. They couldn't even move their razor any longer because they froze that quickly. Some people with Parkinson's disease, and I think the therapists notice this too, sometimes when people are going over a threshold or going through a door, they'll suddenly stop. They'll freeze when they're walking. So those pauses or those freezes are also characteristic of Parkinson's patients who have a fluctuation in their dopamine from the levodopa. So the on-off effects can be a real problem for some patients with Parkinson's disease. And again, the dyskinesias are too much on, and the freezing episodes are the off or the not enough medication. And then, as I said, dystonias are a little bit more unpredictable. They can be the trunk, they can be a foot or an arm. Those dystonias can sometimes be a little uncomfortable too. As I was saying earlier, depression occurs in about a third or more of patients with Parkinson's disease. Usually it'll respond to a simple antidepressant, but as I said, don't use the tricyclics because the anticholinergic activity can make them more confused. There's not a good medication to help people with sleep difficulty, but I generally use melatonin if they can't sleep, and trazodone would be my second choice for people who are having trouble with sleep, not enough sleep. A lot of people have some musculoskeletal pain or paresthesias with Parkinson's disease. I generally stay away from opioids. That is notorious in Parkinson's patients. Opioid medication is notorious for causing hallucinations, delusions, more confusion. Please stay away from opioid medication unless it's absolutely necessary. People with Parkinson's have bladder urgency, frequency, and sometimes incontinence. If they have incontinence, please look for orthostatic hypotension and the Scheidegger syndrome, multiple system atrophy. Constipation, I tell people you can never take too much fiber. If you need something else, there's Miralax. You can treat the constipation as well as I can. The drooling, I do want people to stay away from scopolamine. Scopolamine is another drug that will interfere with people's memory. I occasionally get people sent to me on scopolamine because they were drooling. Well, would you rather have them drooling or would you rather have them confused and hallucinating? I'd rather have them drooling. So now the gait difficulties, I generally have people see a physical therapist because of their gait difficulties, because that's one of the harder things to treat. It's even if we raise the levodopa, it sometimes doesn't help their gait that much. If they're really bradykinetic, it will help, but some people have postural instability that just doesn't really respond to much of anything. There is a special walker that might be helpful for Parkinsonian patients. It's called a U-step walker. So again, when I have somebody who's got a gait disturbance, I generally refer them to the physical therapist. Now, the real problem that I have with many of my Parkinsonian patients that I've been following for 15 or 20 years is that unfortunately as they get older, they're more likely to have dementia. And when they have some confusion and memory loss, hallucinations and delusions can easily follow. And if there's anything I want you to remember today, it's when people are admitted to the hospital with delirium, it's usually because they have a Parkinsonian syndrome or they have some mild dementia, and then they either break a hip or they get septic, and then they get hospitalized, and then they go delirious. And as you probably know, most people who have a severe bout of delirium who have to be in the hospital never completely recover their mental status. Delirium is a very bad prognostic indicator. If people have a hospitalization for delirium, their prognosis is not very good. So again, stay away from those drugs that can make the memory worse, the tricyclics, the anticholinergics, even the dopamine agonists can make people more confused and hallucinate. And then there's not much that works for the REM behavioral disturbance. We sometimes use some Klonopin, but again, that makes people drowsy during the day too. So there's not a good treatment for REM behavioral disturbance. I certainly tell the spouses don't sleep in the same bed because they can get hurt if the person is really moving around too much. So some of the complications that I've mentioned, like the dyskinesias, they can respond to amantadine. We sometimes use Zellopar, Azilect, Comtan. Those can help with the on-off effects, trying to fill in the roller coaster ride so that they don't have as much variation. We don't usually use the time-release carbidopa, levodopa during the day because it's more unpredictable, particularly with proteins. If the people have protein in their diet, it can really make the time release absorption more erratic. So we generally just use the immediate release levodopa during the day. We do use the time release at night when people are in bed because they're not eating a protein snack at bedtime usually. So those time release levodopas are helpful at bedtime. So again, if someone has dyskinesias, we can change the levodopa time. I do have some patients that are taking their levodopa every 2 hours because that's just what works the best, so they don't go into the off periods too quickly. I'm not going to talk too much about deep brain stimulators, but they are definitely helpful for younger patients who generally have had a good response to levodopa, but now they're having a lot of on-off effects or their dosage had to be increased dramatically. So we would refer those deep brain stimulator patients either to the University of Iowa, Mayo, or Nebraska at Omaha. All three of those places do really well with the deep brain stimulators. Now, as I told you, the therapists, especially with our patients on the rehab program, that is really, really helpful in most cases. So as I was saying, with the memory loss or hallucinations, take away most medicines. If they do have really severe hallucinations, we can use either Seroquel, which has less of the dopamine blocking activity as an antipsychotic. There is also another drug that is newer, Nuplazid, that is helpful for the psychosis in Parkinson's disease. I haven't found that it's always been very helpful, however. Some patients with Parkinson's disease get obsessive and compulsive behavior. Some people have pathologic gambling. I had a patient one time that was on ropinirole, a dopamine agonist. They can cause some compulsions that might be pretty bad. You don't want them to gamble away their fortune. Okay, so I'm getting near the end here. Parkinson's and dementia. The older the patient, the more likely they will have some mental status changes. And I spend much of my time with Parkinson's patients who have dementia. They don't take 20 minutes. They take 30 to 40 minutes for them. It's much more complex. Alzheimer's patients are simple and easy. Dementia with Lewy bodies or patients with Parkinson's and dementia and on-off effects, they're much more complex. And the families who care for these people with Parkinson's disease who have some hallucinations, delusions, or confusion, the caregiver stress is much higher, especially if there are delusions, thinking that their spouse is doing something that they shouldn't. So the problem is if you have a Parkinson's patient who has, after 10 years, developed a dementia, or you have a patient who you think is a new dementia with Lewy bodies, it's really hard to differentiate those patients from each other. And that's basically because it's just a matter of where the Lewy bodies are and where they took the most damage. As I was saying earlier, beware of a Parkinsonian patient who has sepsis or a broken hip and comes into the hospital. When they wake up from their hip replacement surgery, watch out for delirium. And that's the same with these patients with sepsis. It's really a high risk. So how you can help someone with Parkinson's, again, as I said, encourage exercise. And at some point, they're going to have to stop driving. There's so much confusion about medication, dosage, and timing, so please make sure their medications are correct. The nurses really need to take care to get the right medicine in the medication reconciliation. And as I was saying earlier, proteins can sometimes interfere with the absorption of the levodopa. And then more fiber is always helpful for constipation. And then, of course, make sure they get enough vitamin D and calcium, so if they do fall, they're not as likely to break something. And then, as I said earlier, the milder drugs, they might help the tremor more than they will help the bradykinesia or the rigidity. All of these drugs can cause more confusion, and some of them can cause nausea and lightheadedness, particularly the dopamine agonists like ropinirole or pramipexole. And then dyskinesias, as I said, are usually in the younger population patients. They're not necessarily a bad sign, but they're always a complication that makes life more difficult for Parkinson's patients. So as I said earlier, Parkinson's disease versus a Parkinsonian syndrome, the prognosis is different, the treatments are going to be different, the family stress is going to be different. Exercise is the only disease-modifying treatment that we have, and the patients who have typical Parkinson's disease with a tremor and unilateral presentation, they usually have a good prognosis for 15, 20, 25 years. Remember to avoid most medications for Parkinson's if they have dementia, and like I say, watch out for those mildly demented or Parkinsonian patients who get admitted with sepsis or a broken bone. So I'll be open for questions.
Muhammad Ali, was his Parkinson's related to repetitive head trauma or what?
Yeah, I haven't talked about chronic traumatic encephalopathy. As you know, football players and boxers are susceptible to chronic traumatic encephalopathy, and many of them had Parkinsonian features as well as dementia. Many of them had personality changes and psychiatric symptoms. There's a high incidence of suicide in chronic traumatic encephalopathy patients. We assume that Muhammad Ali did have chronic traumatic encephalopathy, but there wasn't a postmortem done. But I would assume that that was the case. Now, chronic traumatic encephalopathy is a tau problem. Amyloid is Alzheimer's, alpha-synuclein is Parkinson's. There is a tauopathy, which is frontotemporal dementia or Pick's disease, but the tau in chronic traumatic encephalopathy is in different areas than the frontotemporal dementia. But the tau deposits in chronic traumatic encephalopathy, they can cause a progressive problem over the years that could be Parkinson's or dementia.
A second question, did any of the drugs used for tremor in Parkinson's, do they help essential tremor at all?
No, the people who have essential tremor generally will respond either to propranolol or primidone. Believe me though, over my 40 years as a neurologist, I've thought it was essential tremor, and then I decided, no, it's Parkinsonian tremor. It's really hard in some patients to determine that. So we sometimes just have to try, either the essential tremor drugs or the Parkinson's tremor drugs, and whatever works, we stick with that.
Nice talk, Mike. Are we distinguishing pugilistic Parkinson's from CTE? Are they all on a spectrum, or are they different?
I think we'll find out that basically the pugilistic Parkinson's are definitely chronic traumatic encephalopathy. I don't think, it's amazing how it wasn't even recognized until neuropathologist Bennett Amalu, did an examination of some brains of pro football players, but now it's just the research is exploding. So I definitely think it's going to be chronic traumatic encephalopathy. Snoop?
Thank you. That was a great summary. Several years ago, there was some literature suggesting a link between the use of levodopa and risk of melanoma. Is that still a thing? Has that come on your radar?
Yeah, I had read that too, but as far as I know, there has not been a link established. Okay. So. Yes, we have a Parkinson's support group in Ames, and then there's also one in Marshalltown. It's at the Veterans Home in Marshalltown. I don't know exactly when they're meeting, but I've given talks to the Parkinson's support group many times. And, as I told you, the caregiver stress for a person with Parkinson's disease and dementia is really high. I wish I had a Parkinson's program where we could have a social worker and support. The Wilson Elder Care Center is a good place for people to drop off their loved ones to get them some respite care during the day. But it's really a caregiver burden for a lot of these Parkinsonian patients.
There's a lot of support offered through Iowa State.
Yes.
Yeah. And they offer, in terms of exercise, they offer boxing, dance, singing, and yoga. And there's a support group for spouses, and then also a support group for the patients.
Right. In fact, Elizabeth Stegemuller over at the Department of Kinesiology at Iowa State is actually, she's pretty famous with her research on Parkinson's. And my patients who go to those dance and singing classes and exercise classes, they love it. So I definitely would encourage people to get in touch with the Department of Kinesiology, Elizabeth Stegemuller. So if you have patients that are social, it's a great program. And believe me, singing has some unusual ability to bring out the best in people. So dancing and singing and exercise, that's a good thing. Right. Right.
I'm a Parkinson's patient, and I also go to On with Life in Ankeny, and they have a really good boxing program. They also have 2 programs where you can do exercises that make you big, that help stretch your body, as well as a program for loud, to exercise your throat, to keep your voice loud instead of getting soft all the time.
Right. I think
programs are very
actually
good.
Matt Peterson has been looking into a big and loud program here. I think that some people are doing it here.
I know I've done it, and it does very much help.
Yeah,
And
big
they
and
induce-
loud is what we want, because it really helps to do those associated movements and again get the projection of the voice. So big and loud is another good strategy. Not
Yes, it's a very good
not
program.
every therapist does it, but it's a good strategy. Okay, well, thanks for listening.